At that point, if you're going to place an implant freehand, let's say, let's minimize this for a sec. Um, we have a library here, and we could just choose an implant. How comfortable are you today with these pre-planned or these implant libraries? Are you finding those accurate? Um, what are
Yeah,
your thoughts?
the implant library basically allows you to do a virtual surgery to try in different sizes and lengths of implants into the software, so that it really takes away the guesswork. Um, it takes away the variability of really having to have a whole assortment of lengths and diameters of implants. You can place an implant and be very confident that that'll fit there, incorporating plenty of safety margin from, in this case, away from the inferior alveolar nerve, and know that you have an implant that is ideal for that location. So you give yourself plenty of room that way. The nice thing about once you try an implant in, it's easy for you to, in the software, to adjust to a larger or longer implant, smaller implant. So you can try different sizes in. You can get an idea of what the angulation should be at too, compared to the opposing dentition or the available ridge too. So you get lots of information, even in a free-handed surgery situation, as far as what's available.
What size would you put in this space? A starting point.
A starting point. So I didn't see the actual measurements of the what you had there when you were working on that.
So that is the 11.9. I think that was, let's go here into MPR view. 11.9 was the height to the
Okay.
nerve, and 12.9 was the width, lingual to buccal.
Okay. So this is obviously in this case, this needs to repair more. The root tip needs to be removed. It probably needs to be grafted and repaired prior to placing an implant. This goes without saying. But I think that in this case, first of all, you want to build in a minimum distance of at least 2 millimeters above the inferior alveolar nerve in your planning.
Okay.
And ideally, it's not a bad idea to stay a couple millimeters away from the buccal and lingual cortical plates too. So with that in mind, if we have 12 millimeters, we can easily place a 9 millimeter crestal implant that's even with the crest, and know that we still have 3 whole millimeters below that implant. By
Do
the same
you
token,
do you have an implant in mind before we move forward? Is there anything that
no, you can pick any implant
okay.
line you want. That's the nice thing. That's the nice thing about the software, is that the implant library has every size and diameter of implant that's available, and it's very easy to interchange those. And sometimes, based on your experience with different systems, you may even switch to a different system because of certain characteristics. But here we get the rendition of the implant.
I'm just going
We
to
can
drop
place
that
that.
in there real quick.
We can drop it in, then we can move its alignment and stuff. We can see how it aligns with the see, obviously we have
Too
a
big?
concavity. Yeah, we have a concavity, and we can get an idea of where that is. Of course, there again, we wouldn't put this in without repairing that defect first and making sure that we had good bone there, or at least grafting it at the same time. But I like to just repair them in advance. It's a little bit easier and straightforward, but we obviously have a concavity, right? So we can go quite a bit shorter. You can see the outline of the inferior alveolar nerve. We can make sure that we have it at crestal. I mean, some implants are supracrestal, depending upon the system. Some are crestal, some are subcrestal. An ankylosing implant would be, 1.5 millimeters, 1 to 1.5 millimeters subcrestal. So it really just depends on the system you're working with.
Okay.
That's okay. You can easily accommodate that and place a shorter implant. And then we can look at its angulation as opposed to the opposing dentition, and get an idea of where that is. Very important in a case like this. Conebeam is a game changer. If you look at the implant on the other side, can you bring that into focus, the one you see over there? Yeah. Now, this was obviously probably placed freehand. If you look, the implant is over-angulated to the lingual.
Okay.
If they went straight up and down with that implant from that same position, they might have got through the cortex at the apex of that implant. If you look at the apex of the implant that's already there,
Yeah.
and they went straight up and down, which would have been a better alignment for the opposing tooth.
Okay.
They could have been into that space, into that little notch there.
Yeah.
And that would not have been good, because anatomically that not only, it's bad enough to be near the inferior alveolar nerve, but the lingual artery and a few other anatomical things are in that space too. So you can have a major problem if you make a penetration there. And that's one of the great things about Conebeam. When you have three-dimensional information, then you can avoid a lot of problems.
Okay.
And so you can do better planning, and in this case, know where that your starting point should be. It probably should have been started a little bit more to the buccal, that free-handed implant, and it probably should have been at a little bit better angled a little bit more towards the buccal. And like everything in life, it's very easy to, Monday morning quarterback these things after the fact.
Sure. That explains the little counter lever there.
Yeah, exactly.
Okay.
That explains the cantilever, and that looks like it would be, could have potentially been a problem, but it worked out okay.
Okay.
There was a short enough implant. The nice thing about having the implant library is you really know what size is required before you get started. In the earlier days of implantology, we had to have an inventory of implants in the operatory at the time, because oftentimes we would end up having a narrower ridge than we thought once we were only using 2D information. And so we ended up usually going narrower and shorter both, a lot of times in a freehand situation. And in difficult locations and difficult areas, those are all certainly indications for guided surgery. And the profession is heading more and more in that direction. We're getting better and better at it. But it is important to know how to do the basics of freehanded dentistry and freehanded implantology, so you're used to working with bone and dealing with things in case your guided surgery has problems. So
sure. Okay.
That's a really good case, because there's on review, I'm sure clinically there's plenty of width, there's plenty of height, but in this case it really helps to have it at the right angulation too, for the opposing dentition to avoid that cantilever and to avoid anatomical structures. I mean, that's the first most important thing we need to do, is to avoid anatomical structures and stay away from them.
Yeah. Okay. Great. That's a good overview on this case, and there's a lot to see here. So
yeah, there is a lot to see, and I think that the one thing that I can say is that although we're certainly looking at implantology, and there's lots of opportunities for that in this case, if you take a look at tooth number 15, it may be an asymptomatic case, but you're going to find things that you've never seen and make better clinical decisions about cases when you can look at that. Let's look at the sagittal view of that, if you can.
Okay.
Of number 15, if we can.
You're gonna have to guide me about. Is that this one? Or are we here?
Yeah, we're right there.
Right there, correct?
Right there, yes. So let's make that full screen, and then if we zoom in on that, you can see that there's a very large apical lesion around the mesial root of that tooth.
Oh, right here.
Yeah. And there again, incidental findings in Conebeam are there every day. It's a regular routine thing, because there's an increase of about an average of about 30% in diagnosis with Conebeam compared to a traditional FMX, even a digital FMX, because we're looking at things in 3 dimensions and we're seeing things that we've never seen before. So you can pick off a lot of other problems and get ahead of it, and you can do a lot better decision making when you can look at things in 3D.
Great. Well, thanks for taking the time with me to take a look at this case. And if you have some time later on, we'd love to jump on to a different case and get your thoughts on it.
Great. Let's do it.
All right. Thanks for joining me.
You're welcome.